Everyone, my name is Morgan. We are going to get started this morning here at the top of the hour. Um, just getting everything set up here. Okay, looking forward to it. Hey, good morning, everyone. We are going to get started here in just 2 minutes, but I would like to just take this moment to tell you all about some exciting things we have coming up. On July 19th and through the 21st, we will have our live review. So this is a 3-day intense, in-depth review of just everything to get you prepped for the boards. So we will cover all those hot topics. It does go pretty quickly through everything, but just making sure you have all of the knowledge that you need. It comes along, we'll give the 30-day free trial of the question bank. If you want more, you can pay just $29 for 2-month access. I just recommend people to definitely get into that question bank. There are so many questions, and the more questions you do, the better it will be for you. Just preparing yourself for seeing these questions and kind of knowing how to answer all of that stuff is really going to help you. Just be ready for this for this exam. Okay. So really, really good. If you are interested in signing up for that 3-day, you can go ahead and just click or scan this QR code and get yourself registered. We will have more of those coming. And then there's the self-assessment that you can do, and not just the readiness assessment. And that really helps you understand and take some practice exams that can really help you understand where you are and then where you need to focus. So go ahead, click on our website and get some information so that you are ready for this, okay? We will get started here in just one moment. All right, everyone, good morning. My name is Morgan. I am a family nurse practitioner, and I am here to talk with you guys today about mental health psych, just some of the basics that we're going to cover today for your boards exam. Um, just a quick reminder, we do have that 3-day live review coming up here next month to kind of help get anybody prepped. If you need any additional support, this is a really great opportunity. We did one last month. It was super, super successful. We've had a ton of positive feedback coming back at us. So go ahead if you are interested, jump in there and scan this QR code to get registered for that upcoming 3-day live review. Okay, so we today are going to talk about anxiety, depression. We're going to cover a little bit of bipolar, schizophrenia. This is not meant to be a super deep dive. Unfortunately, we just don't have the time. But I want to review the screenings, the diagnostics, and then some treatment for our most common mental health problems that we're going to see in the primary care setting. Okay, if you want more information, we do have on-demand videos that go a little bit deeper into all of this stuff. So feel free to reach out on that as well. Before we start today, I just want to do some positive affirmations. Just remember, you know this information. Everything that you are being tested on, you have stored in your brain. It's there. When you're sitting down for your test, go ahead, take a deep breath, and just focus. And just tell yourself that you know all of these things. The answer is there, and you have the capacity to pass this exam. Okay, the NCLEX I thought was way harder, so you guys are going to do great. It's a beautiful day here. I am located in Denver. It's morning, so for everyone, I think even on the East Coast, we're still ahead of noon today. So good morning, everyone. I hope you're having a wonderful start to your day, and let's jump right in. Okay, so when we're talking about any sort of mental health stuff, we're going to start with the Diagnostic and Statistical Manual of Mental Disorders. This is also known as the DSM-5, is the version that we now have. When I was in school, we were still using the DSM-4. So this is something that the American Psychiatric Association is always updating and working on. And you're going to learn that maybe things that you learn today aren't going to be necessarily the same as what we're going to use throughout. And that's kind of the way medicine goes, right? We are always learning. And that's why I love doing this job, because it keeps me fresh and learning all these new things, because what I learned back in school is no longer the way we do things for a lot of different diagnoses. Some things maintain the same, but we're constantly learning. So it's important just to make sure you're using the most up-to-date manuals for your diagnostic criteria. So when we think about the DSM-5, it really is outlining specific symptoms and criteria that must be met for us to be able to diagnose somebody, okay? This is a guide to help clinicians diagnose mental conditions in people. This is NPs that we can use this. We can also send off to psychiatry. So if you're not comfortable making a diagnosis in the clinic, you can always refer somebody out, but this is just kind of a good guideline to show this is what needs to be, this is the criteria, and this is how a psychiatrist is going to go ahead and diagnose somebody. So it's a really, really great tool for you to have. All right. But then we have screening tools. We're not going to dive into all of them. There are a lot of different screening tools. The ones that I use in my clinic, PHQ-9, GAD-7. We also have the Beck Depression Inventory. That's for people 13 and up, and then the Geriatric Depression Scale. Because of our age and the way that maybe certain things would be interpreted, we can use different screening tools for different ages and maybe target that more. So if you're working in a geriatric setting, you may want to just adapt that tool for your practice. And by no means is there one that's necessarily superior. I would say it's really, really dependent on your population that you're serving. With me, I do a full family scope. So we do use some child questionnaires when we're working with kiddos. But for the most part, it's the PHQ-2 is going to be our screening. And so my MAs administer that to all of the patients as they come in. And then if their PHQ-2 is positive, we're going to go ahead and give them the PHQ-9s, and we'll talk about those in just a second. GAD-7, it was in the past few years, the PHQ-9 and GAD-7 have been on the same form, okay? A lot of people are giving both at the same time, and they're just grabbing both of those. A recent report just came out in the efficacy and the need to check for anxiety in the primary care setting and screen for it. And there's kind of, I think we don't quite know if it's necessary or not yet to do that. We still do it in my practice, but I'm going to say that might be something that you guys are going to see might be kind of phasing out, that we're no longer assessing for anxiety like we used to, or like we currently do, I should say. All right, but to speak a little bit about the GAD-7. So this is Generalized Anxiety Disorder 7. It's 7 questions. That's why it's 7, easy to remember. Okay, so this is a self-administered questionnaire. We don't ask these questions to our patients, we're handing them this questionnaire. We need to make sure first they're literate, that they can read these things. So giving it in the correct language is also very, very important. But making sure that your patients can actually read and understand this, because you would be surprised about that. And we know if we're reading it to patients, say they forgot their readers, that does kind of affect the way a patient may answer some of these questions. So just things to keep in mind. All right. So when we're doing the GAD-7, it's just like it's in the name. This is really looking for symptoms. It's 7 questions. It inquires kind of about the most common symptoms that we see in anxiety, such as excessive worry, restlessness, difficulty relaxing, irritability, muscle tension. We may see some sleep disturbances, difficulty concentrating. And what we do is we score each item from 0 to 3. So the total score ranges anywhere from 0, no anxiety, to 21, which would be pretty severe. And then we have minimal, and you can see here 0 to 4, 5 to 9, 10 to 14, 15 to 21. I do recall a board question kind of focusing a little bit on this. By no means do you need to go in and remember every single one of these numbers, but kind of have an idea that there is minimal, mild, moderate, severe, okay? And it's 0 to 21. And so that is how we score them. We want to talk to our patients if this becomes, if there's anything more than mild anxiety. I like to have a conversation about any positive that I see on this and just kind of ask, is this situational or is this something that's going on? Is this your baseline? Where do you live? Kind of. All right. And then next, and probably the most important screening test that I do at least once a year for all of my patients is the PHQ-9. This is Patient Health Questionnaire. It's 9 questions. Again, it's a self-report tool that we use here to assess and to monitor progression of depression symptoms. Okay, so we can see our severity, and then we can see, like, are we making any improvements? So different people are going to use a little bit different techniques here as far as how they're going to go about using the depression, the PHQ-9. But the way that I like to use it is I use it as a screening tool. I have my MAs always do a PHQ-2 on my patients just to see where they're at and if we have anything that's changed as they're coming in. And then I use a PHQ-9 at their annual physical, or if I'm just meeting them for the first time to see if we have anything that maybe we need to prioritize. Okay, so here we're looking for symptoms of depression. This matches up with your DSM-5 criteria for the diagnosis, okay? And they're, again, looking for common symptoms of depression. So when we think of depression, we think of a depressed mood, anhedonia, changes in weight or appetite, sleep disturbances. We consider psychomotor agitation, or kind of just slowed psychomotor stuff. We can call that retardation. Just when everything's just so slow and it's hard to have that energy, fatigue, feelings of worthlessness, guilt, difficulty concentrating. Okay, as you can see here, a lot of these things are gonna play in different areas, right? So if we have difficulty concentrating, maybe we have ADHD or something like that. Or maybe there's something going on in a situational thing. So never is this to be taken as a complete, the screening's positive and therefore I'm going to diagnose somebody. No, this is a screening tool. More conversation needs to happen. The one thing that I really want to hit hard on here is kind of the severity. I think of question number 9, that's our suicidality question, as the one that should always, always be looked at and examined and talked about if positive, okay? So we have our scores 0 to 3, again, assessing how often people are experiencing symptoms. And then our scores range from 0 to 27. Okay, so 0 to 4, minimal, 5 to 9, mild, 10 to 14 is our moderate, and 15 to 19 is going to be moderate to severe, moderately severe, and then 20 to 27 is severe depression. All right. When we consider a positive, it's anything above 9, but we should, again, talk to people. Okay, now let's just take a moment and talk about suicidality. When I see question 9 circled, that is going to put a major stop in my day, okay? And I'm going to go ahead and explore that more with the patient. I think it's super, super important that we don't veer away from suicidality, that we open it and we have a conversation with our patients. This is extremely, extremely important. And they say that most people who end up dying by suicide have seen a healthcare provider within 2 weeks of their death. And so that tells us that people are coming to us, okay? People are walking into our office and they may not be able to tell us why they're there. And that is why getting more questions, asking more information, and really sitting with patients, sitting with some pauses, sitting with some empty, um, sitting in that silence and really just giving patients the space to open up is going to be super, super critical. And I can't state that enough. Um, so the kind of the way that I like to approach this, if somebody has circled question number 9, I pull up the thing and I say, okay, like I see here that you circled this. Can you tell me a little bit more about about where you're at today and what's going on? And I just leave it open. And you have to be comfortable with a pause. Oftentimes, patients are going to take a minute to kind of gather their thoughts and figure out how are they going to tell you this? Because this is a really stigmatized feeling that people have. And now we're sitting here and they have to open up, maybe for the first time, about where they are on this spectrum. And I like to tell patients, that suicidality is a spectrum and we need to understand where they are so that we can intervene and we can do something to help them. All right. If we have active suicide ideation, if somebody has a plan or homicidal ideation, then we need to intervene now. Okay. This is not something we can do. This is a conversation with my MA. Hey, I've got a situation and I'm gonna get behind in my patient and just start kind of figuring out what is it we're going to do. Assess for their safety is the most important thing. So when we ask about plans, then we can use the Columbia assessment and go ahead and just kind of follow that all the way through and making sure that if we need to get somebody into immediate care, we get them into immediate care. All right. So by no means do we just kind of slide by this. It can be very, very difficult and you will get better, but please don't shy away from these conversations with our patients. All right. One little keynote that I really, really loved just to talk about when somebody does disclose to you any sort of new anxiety or mental health concern that they have. One thing that science has shown is really helpful, and it's so easy to do, is just being that kind of that key person for them. And a handwritten note, it was really nice to meet you today, and I'm looking forward to working with you. And that gives somebody, and so I have like little postcards that I give when I meet patients for the first time, and I hand it to them, and it gives them just kind of like a string back to me that I really do care, and I'm going to be here for when they're ready to come and talk some more. Okay. That's somebody that I think is safe leaving the clinic, right? But something that can just be kind of nice to build that relationship with your patients, and it's been shown to really help people come back to us and keep the retention and start that relationship in a really positive way. Okay, anxiety. Anxiety and depression, probably the most common mental health related conditions that you will see in the primary care setting, but really any setting. So it's really important that we recognize the signs and symptoms. We know the basics about treatment, okay? We can refer out, but oftentimes those wait lists are so long, guys. We have to be comfortable. So figure out a couple of your medications. We'll go over those and I'll talk to you about my favorite medications that I use. But have the doses down, have the side effects, have the contraindications, know your kind of tools that you are going to use, and then you can just feel really comfortable about offering medications, talking about medications with your patients. Okay, anxiety, like we said, common thing. It's really characterized by these persistent feelings of worry, fear, unease. It can interfere. So I like to say, it's normal. We all have anxiety. That is something that we were given to protect us, right? But once that anxiety is interfering with our daily function, maybe we're avoiding doing something we need to do. We're not going into the grocery store because we're worried about being around crowds, or different things that people may feel triggered by. Once it starts interfering with their daily activity or their quality of life, that's when it starts to become an issue. Okay, that's when I tell patients, if you just are a nervous person, that's one thing, but you're still able to kind of cope and you can get through it and you do what you need to do without making huge changes. and really, really like imbalancing your life because of your anxiety, we can go with that. That's okay. However, if we're starting to really, really change our daily patterns because of our anxiety, that's when we kind of can intervene. All right. So why do we have it? Well, it's kind of complex, guys. None of the stuff is really straightforward. And the science that we know right now really seems to think that it's an interplay of genetics. So there's some sort of gene in there, but also our environment, and then our neurobiological factors, neurotransmitters, which particularly think about serotonin, norepinephrine, and GABA. Okay, these seem to play a really, really big, crucial role in regulating our mood um, and our anxiety. And then this dysregulation of these neurotransmitter systems, they kind of seem to play a big role, including like the amygdala, the hippocampus, our prefrontal cortex, which is our judgment, and all of those together kind of seem to come into play and cause what we would consider pathological or anxiety disorder. Okay. It can be many, many different ways, but like I said, if it's really getting into our function, that's what we need to worry about. Can you put into the chat what when somebody comes in and they're maybe telling you about some of these things like tachycardia, shortness of breath, feeling just really tense, they can't sleep, they're worried. What other things might you want to think about before you're giving a diagnosis of anxiety? Go ahead and write it in the chat if you can. And let's see here. Depression, cardiac issues. Yep, absolutely. Anything else that you guys can think of? Okay, awesome, guys. Cardiac issues is really what I wanted to get at. So before I'm giving an anxiety diagnosis, I am making sure I'm not missing anything going on physiologically in a different part of the body. So I think of the thyroid as well. And so when somebody comes in at that first time, and if we haven't had any baseline labs or anything like that, I may be getting some stuff to make sure that I am not missing something like a heart attack or a hyperthyroid state. So if our thyroid is over functioning, we can actually get that tachycardic feeling and that kind of anxiety and stuff like that. Anemia. So make sure that our CBC is normal, making sure that we're not missing anything else, and really asking about those cardiac red flags. Okay. So we want to make sure we're not just jumping straight to an anxiety disorder diagnosis. That is kind of a little bit of a diagnosis after we exclude the red flag things that can really upturn our life. Okay. All right. The next thing I wanted to talk about is the workup. Yep. So we kind of hit on that a little bit. So you can go ahead and grab some of those labs. I think it's super important. If you're worried about a heart condition, get an EKG. Maybe might make the patient with anxiety feel better if we got us an Holter monitor. Are they feeling palpitations? If so, let's see what's happening physiologically with their heart electrically. What is going on in that heart muscle when they're feeling these symptoms? Because maybe they are having something going on there. Okay. Again, we're going to use our GAD-7 here to kind of understand where we lie. And then again, I like to use that as a progressive kind of and monitor our improvement. So if we start doing these things, are we making anything better? All right, so talking about pharmacology, I'm going to jump into these a little bit more in depth here in a moment, but SSRIs, SNRIs, benzodiazepines, I really, really try to stay away from benzodiazepines. They do work, but they do cause dependency. And when people take a benzodiazepine, they feel so much better so quickly that then they can become kind of reliant on it. So it is a little bit, for me personally, it's going to be something that I use as a last resort for somebody who has some pretty severe panic and stuff like that. The mainstay for anxiety treatment we know is going to be psychotherapy, and it's specifically the cognitive behavioral therapy. All right. We need to make sure that we're getting exercise, sleep, stress management. Are we eating right? Making sure that we're doing all those lifestyle changes. In addition, I like people to journal is something else we can really look at. Okay, I got to keep moving here. Depression. So really, really common that we have anxiety and depression together. That's why we see a lot of the same medications used in both of these, okay? Um, we think a lot, this can happen at any age, all genders, all backgrounds. Triggers, again, we're thinking genetics. Is that we're genetically predisposed, but then we have biochemical imbalances in the brain, stress, trauma, medical conditions. Okay, so it's really important that we're doing our screenings, the PHQ-9, and then really looking at what's going on and asking people where they are. We kind of talked about this a little bit. These are the symptoms that we see, but we can also have some physical changes that people have. So that's like sleep issues, fatigue, lack of energy, changes in weight, changes in appetite. All these things we need to talk about, and again, assessing suicidality. All right. As far as our workup goes for this, again, we're making sure there's no other organic causes happening, like vitamin deficiencies, thyroid imbalances that could exacerbate or be causing our depression. Medications also, what are we giving people? How about alcohol use? Stuff like that. We want to ask lots and lots of questions before we just jump right in. And then we also want to make sure we're not misdiagnosing depression when we think somebody could have bipolar or some other stuff, but we'll talk about that in just a moment here. All right, so SSRIs, SNRIs, again, therapy, super, super helpful, and lifestyle modifications. I always start with lifestyle modifications. If somebody's kind of mildly depressed, if they're extremely depressed, I think, and they're asking for medication, then we'll have that conversation. But it's really just patient dependent, and I let them really lead the conversation. They came to me, they wanted to have this conversation, and my guess is they already kind of know what they're looking for. And so I'm there as a guide, okay? If they want to go more a natural path versus more a pharmacologic path, that is something we're going to talk about together. Okay, some other quick disorders that we're going to jump into, the things that you're going to see, bipolar disorder. Okay, lots of stigma here. Let's kill the stigma. There's no need. Any of these mental health disorders, they affect all of us. We know somebody, may have a family member, it might be us, who has some sort of thing going on, and it could be temporary, it could be permanent, but let's just kind of drop the stigma around all of these things. Okay, so bipolar disorder characterized by cycles of feeling really, really up and mania and then depression. Okay, so there's two types. We have the one, type 1 bipolar, major, more swings. Okay, we just think of like our ups are up and our downs are down, versus bipolar 2, and that curve is just a little bit smaller, and we think of hypomania. Okay, so just episodes that are a little less severe. We see maybe in type 2 that we stay kind of more in that depressive state a little bit longer, and then we come up to a hypomanic state, and it's just like the wave is a little less, versus bipolar, I like to think of it as a bit more severe and cyclic as well. All right, we see this most in young adults. Can be kind of hard to distinguish depression from bipolar. So that's why we have to administer our criteria, or our, oh my goodness, the mood disorder questionnaire can help us distinguish between bipolar symptoms, right? Do we have any of these periods of kind of impulsivity, or like making intense decisions, and maybe like feeling really, really grandiose? Okay, those are our manic kind of signs and symptoms. And if somebody's experienced that in the past, then we need to be careful, because if we use an SSRI in a person with bipolar disorder and they're down in that depressive state, when they come in and we think, oh, this is, just depression, the problem is that we could actually send them into a manic state when we give them an SSRI. So we don't want to miss this. So if you're thinking about starting an SSRI in a patient, I always, always, always recommend you to get an MDQ. That's the mood disorder questionnaire, because it helps us rule out any kind of risk of putting somebody into a manic state with an SSRI. All right, and when we think about treatment, we think of lithium. Yep. So that's that medication with a very therapeutic range that we're going to be monitoring levels. But this is a mood stabilizer, kind of helps our patients not go have those big swings and helps them just ride where we all want to ride, right? Just on the normal mood spectrum here, so that they can be functional in their life. And that's kind of the goal that we talk about with our patients, is like just function so they can have a stable life and feel good and not feel like in their lows. Okay. Um, and you will see psychiatrists using SSRIs and SNRIs. However, in the primary care setting, I rarely start medications. If somebody has bipolar disorder, personally, I'm getting those people into help. I'm happy to bridge medication and continue to take over from that perspective. But if folks are coming in, we're not quite sure, I'd like to get some of that support from my psychiatry friends, and making sure we're making these correct diagnoses and we're starting medications in a safe way, because it can have a little bit of some pretty severe effects if we choose incorrectly. Okay. Very quickly, we're going to go over OCD. This is not that common, but it manifests in ways that can really disrupt people's day-to-day lives. Okay, so when we think of OCD, this is a chronic mental health care condition, and we think of recurrent intrusive thoughts or obsessions, repetitive behaviors, mental acts, compulsions that individuals feel just totally driven to perform in response to their thoughts. So we can see folks in lots of different ways, but it's unwanted. It's these urges that really cause anxiety or distress. So it revolves around things like contamination, fear of harm, asymmetry, everything needs to be symmetric, or just kind of like these forbidden thoughts. Then we have compulsions, which are repetitive behaviors or mental acts that individuals feel kind of compelled to perform. Okay. So when they do this thing, if they turn off the light, turn on the light, it alleviates the anxiety. If I check the door, make sure it's locked, it makes me feel better. Okay. They can include rituals like washing your hands excessively, checking, counting, arranging items in a particular way. You may see these kind of start off in younger children, okay? But it can come concurrently with, oh, sorry, am I cutting out here? Can you hear me, guys? Hello. Is control. Is it cutting out here? I'm gonna put in my headphones away and I'll go switch over to the microphone in here. All right, can you hear me now? Yes, okay, sorry about that. Great. I think it could be I got some new headphones and I thought I switched the noise cancellation on them, and hopefully, but we'll give it a shot. Okay, let's see here. So let's jump forward to treatment for OCD. So this involves a combination of both our psychotherapy, and we can also use our medications as well. We go straight to our SSRIs for OCD, okay? But the mainstay is really going to be our cognitive behavioral therapy and exposure therapy. This is where we hear exposure and response prevention is really the first line for the OCD. So the way this works, it kind of exposes an individual gradually to the feared stimuli or the obsessions while preventing the associated compulsive behavior. So this helps individuals learn how to kind of tolerate their anxiety without engaging in the compulsions, and it leads to kind of improvement in their symptoms over time. All right, so we can, again, use the SSRIs that will help alleviate some of these symptoms, but we really are going to work on kind of that exposure and not having that same track. So we have that super highway of this trigger comes in, this is my response. We're trying to break that track, that super highway, and we're going to try to rewire the brain so that we can understand there's a different way to respond. All right. Schizophrenia. So this is kind of an interesting thing, but really pretty devastating. So it's a chronic severe mental disorder.
These folks have been stigmatized for years and years, and we're trying to figure out the best way to help families and patients who suffer from schizophrenia. Again, if we can get folks on medications, it can be very, very helpful. It's a scary disease to live with for both patients and families, and I think it's really important to understand what those symptoms are and how it can be very, very fearful for folks who are living with schizophrenia. We often see this kind of manifest late in adolescence or early adulthood, but it may go unnoticed. And so it can be diagnosed later in life. There are two sets of symptoms associated with schizophrenia. So we have our positive and we have our negative symptoms, okay? So when we think of positive symptoms, these involve behaviors or experiences that are added to a person's normal thought processes, okay? These can include like our hallucinations, delusions, kind of that disorganized thinking, may see a little bit of unpredictable behavior because if you think about it, these people are living and seeing and feeling and hearing things that we are not aware of. And so their behavior may become a bit unpredictable. The negative symptoms that we think about with schizophrenia are kind of more of those things that kind of put us down. We think of the 4 A's. We think of affective flattening. So that's that person who just has no affect, okay? And then we also think of kind of the avolition, which is kind of just decreased motivation, algolia, or the reduced speech, anhedonia. They don't really seem to get much excitement or pleasure out of activities. Maybe before these folks, loved different sports or things like that, and then it's just kind of just seem to veer off path towards that late adolescent, early adulthood stage. And then depression. So we see these kind of all coming together, and it's important that we think about what else might be going on, okay? And looking towards the positive symptoms, I think of, the added experience, okay? So this is the hallucinations, delusions. Negative is all those things that are kind of pulling somebody back away from us, okay? So that's how I want you to think about those for your exam. As far as treatment goes, hospitalization may be needed, short-term, long-term, to kind of help get symptoms under control and figure out the correct medication for these people. In and out of hospitals tends to be our current pattern right now that we see with folks as they're trying to understand what the best medications are. Unfortunately, our medications do have a lot of side effects and they don't necessarily make people feel great. We have our first generation, which were our typical antipsychotics, and then we have our second generation. We'll go into those. We typically are using the atypical, we are more likely using the atypicals because of the lower side effect profile. So when we think of side effects with these guys, it's kind of that tardive dyskinesia that we're worried about, okay? People don't like to feel the way that some of these medications make us feel, but we'll jump into it here in just a moment when we go into our med review. Most important is that we have good supportive all-encompassing services for these folks to really help them be able to participate in life and function at their highest abilities, okay? With schizophrenia, it is a disorder that when we are working with patients and we're looking at like an MRI of the brain, we actually see some changes in their MRIs that suggest the frontal cortex starts to kind of atrophy a little bit. And so when we see some of these symptoms, you think of judgment and kind of this overactive part of their brain. We definitely think about how judgment is impacted. And so our frontal cortex, that is developed, that's the last part of our brain to develop. And at age 25, we assume that that's when that's fully developed. And that's about the time where a lot of these symptoms seem to really show themselves. So really remembering the frontal cortex in folks with schizophrenia, on MRI, on imaging, we will actually see changes that occur here. Okay, so medication review. I want to spend some time here, guys, because I think this is really important that we kind of know. So our first medication classes that I want to kind of go over is the SSRIs, selective serotonin reuptake inhibitors. And that these guys really, really seem to work by doing exactly what they say. So at the synaptic cleft, we have one synapse, one neuron is going to release serotonin to the others, and then whatever serotonin is not used will be recycled back to the previous neuron. What these medications do and how they work is we see a down regulation in folks with depression, with anxiety, a down regulation of the receptors on the receiving neuron. Okay, so they may be spilling out some serotonin to help pass on a message, and then there's less receptors, and so that message kind of gets lost and so forth. What happens when we give an SSRI is that medication, it slows the reuptake, it slows the recycling process so that the serotonin is going to sit in that synaptic cleft a little bit longer. And in about 4 to 6 weeks, what happens in the body after we do this is that we start to upregulate receptors on that receiving neuron. Okay, so that is an upregulation. And so now all of that serotonin has a place to bind and continue to spread that message through. So that's the way I explain it to my patients, is all we're doing is we're slowing down a process. We're not going to make a person happy-go-lucky if they weren't happy-go-lucky to begin with. We're not changing your personality here. All we're doing is trying to improve the placeholders for the neurotransmitters that our brain is naturally releasing. And in about 4 to 6 weeks, as we keep that serotonin longer in the synaptic cleft, we're going to see the upregulation of our receptors, and then that's going to help, okay? So this is not a medication that we feel different right overnight, right? So if we give somebody this medication, what can you guys tell me one education piece that you may give, especially in adolescents when we're starting an SSRI, something that we need to be on the lookout for. So, and then in adults too, as we're kind of giving them more energy, what's one red flag sign and symptom that we should talk about when we're starting this for somebody who maybe has been suffering with depression? Weight gain, yep. So we can see that. How about something really concerning? So as we're giving people medication, they're feeling just a little bit more energetic. What might happen next? So the thing that we want to always talk about with people is suicidality, okay? We don't want to miss it. When somebody's feeling pretty, yes, following through on suicide plans, awesome. That is exactly what I'm getting to. So we have taken somebody who's depressed, we've given them just a little bit of energy. Now they have the energy to carry out those plans, okay? So making sure we're having those conversations, putting in place a prevention plan. The contracts, I don't think those really work, but a plan, who are you going to call? I always have my patients pull out their phones and save the crisis line in there. They have direct access to our clinic 24/7. We have an answering service that will push through any suicidality to us. Who is their call person? Who is their safe person? Do they have the means to carry out these plans? Do they have firearms in the home? Stuff like that. And if so, let's take those out. Let's just eliminate anything. And I always tell patients, we will get through that, okay? So let's not make any rash decisions. Let's work together, come to me, come to somebody if you're feeling suicidal, because we know that most people will get to a point where they feel better and we can help them. So giving them that reassurance, but asking these questions, making sure that we know when we are prescribing SSRIs that we are following up on that risk. Especially it seems to happen in adolescents when we start these, that we can see an increase in suicidality in that first month of medication. Okay. Again, we kind of talked about how they work, and then we titrate. So we go up every 4 to 6 weeks we can go up, definitely as often as we need. I probably about every month will make an adjustment. So I like to see how we're doing at 4 to 6 weeks. Okay. And then we go up. My favorites that I use, I go to escitalopram a lot because most of the people We don't want the sexual side effects that some of these come with, okay? So we see less of that, less of the weight gain on escitalopram or Lexapro. I also like Zoloft, sertraline is a go-to for me. Like I said, choose your favorites. Those two are my favorites, Zoloft and Lexapro. It's where I go. Lots of people do well on Prozac. But we tend to see a little bit of the sexual side effects there. So making sure that we're talking about this. And then anybody who's on the MAOIs, I don't really ever see them used any longer. I'm guessing that's going to be more in the psychiatry use, but something to kind of think about as well. Okay. Learn the two or three medications that you like, get those doses down, get their contraindications down, really feel confident and just like, this is where I start and this is where I go. Okay. SNRIs are another really great class of medications, and they work similarly to the SSRIs. The only thing is now we're adding in the norepinephrine. So we're just kind of like one more thing, one more bump up. And I tend to go ask my patients, do you have family members with similar symptoms? And if so, I always think of this when I think of SNRIs, because I had a patient tell me, hey, my brother has used venlafaxine and it worked very well for him. And I say, great, let's start there. There's no right or wrong way to choose one of these medications for your patients. But if they have the confidence to have these conversations with family members, there seems to be something that works well for a family member. It may not, but it may really work well for that person in the same family. And so that can be a conversation and a starting point as well. Okay. With the norepinephrine, we kind of see that it adds a little bit of that arousal or alertness, maybe some memory improvements and attention. But again, it's that reuptake that we're just slowing down the recycling. And so we're letting these neurotransmitters sit in the synaptic cleft a little bit longer so that over 4 to 6 weeks, we see that upregulation in the receptors, okay? Sometimes these medications don't really have any effect. That doesn't mean we just get away from the entire class. We just switch to our second choice. So if I start somebody on escitalopram, they come back to me in 6 weeks, they feel no change, no difference. We could increase the dose, or we could say, you know what, if there was no change whatsoever after 6 weeks, not a single drop in the hat, I would say, let's just go ahead and try sertraline or Zoloft, okay? And maybe just that switch in the same class of medication, I'm just switching the different type, I can see an effect, okay? This can be a frustrating process for a lot of folks because we might not get it right on the first try. And so I try to tell people that we're going to do our best. There's no there's some of that genetic testing out there, I think, especially around these medications to say that like they're going to metabolize this at a certain rate. And so this medication will work better in this genetic code. I'm not certain how effective that is. In my practice, we don't have that, but I'm guessing in certain practices with more resources, potentially people are using that. I don't know how great the evidence is around it. It seems like it's kind of coming and going. However, if it's something that you can try to utilize to help your patients, I don't see a harm in it. It just kind of depends on what is available at your clinic. Okay. One quick thing on the SNRIs, if we have uncontrolled hypertension, it's something we want to be careful about, okay, because it's an excitatory hormone. This can cause a little bit of a backfire of panic and anxiety. However, we use the SSNRIs a lot in our anxiety patients. I'm going to take a quick pause here and talk about something that I also like to use. Sorry, I don't have a slide for it. When somebody has panic and we're starting an SSRI, we can use benzodiazepines. And like I said, I don't like to go for those because of, they work so incredibly well that sometimes the risk is that people will say, well, I don't want to take this SSRI. I just feel so great with my benzo. And so I'm just going to use that 3 times a day because that seems to get rid of all my symptoms. Well, eventually we can develop some tolerance to that. And it's a medication that we also can become physically dependent upon. So rather than choosing and going straight for the benzos, I do use them, but they're not my go-to. I use hydroxyzine, and I can also use propranolol if there's no cardiac signs or symptoms. And basically, those medications will help kind of with that panic stuff, okay? So if somebody's coming in, they're having a lot of panic attack, 4 to 6 weeks is a long time to wait to get the effects from these SSRIs or SNRIs. So we can use hydroxyzine and also propranolol, low dose, okay? And make sure we're asking all the questions around cardiac signs and symptoms to use that. Excuse me, I'm just gonna grab a glass of water. I am recovering from COVID, guys. I know it's back out there. I tested positive on Monday, and so that's why I'm all congested. I have COVID. It's kind of crazy. Okay. So yeah, any questions about that hydroxyzine or propranolol for anxiety and panic? It's just kind of a good medication to couple with your SSRI when you're starting for folks that have those things going on. Okay, tricyclic antidepressants. I don't tend to use these very often for depression. I use them a lot for things like chronic pain, fibromyalgia, stuff like that. Amitriptyline is my go-to for those. They're not necessarily a first line any longer. These are older medications. We used to use those. Oh, yeah, COVID is picking up. Yes, it is. Okay. But when we think of the side effects, we think of that you can think TCAs, okay? Tachycardia, cardiac effects, anticholinergic effects, sedation, sexual dysfunction. They have a lot of side effects. That's why I don't tend to use them too often. They are great for like migraine prevention, stuff like that. We can use low doses in the evenings, reduce those side effects. But yeah, not my favorites, something you should know about. So the amitriptylines, nortriptyline, doxepin are all under that category. Neuropathic pain, urinary incontinence are some indications that we actually use those medications for as well. And then the MAOIs, honestly, again, not a go-to for me. You may see somebody coming from psychiatry on one of these medications. Lots of side effects, lots of drug interactions, not my favorite, okay? Now, I don't know that I have actually ever prescribed one of these guys. I have seen people on them, and I make sure that I'm very careful around any prescription that I'm writing that may interact with this medication, and I'm looking at my drug-to-drug interactions all the time if somebody's on one of these guys, because there are so many, and that's probably why we don't use them very often. They are really working, this medication works by inhibiting the enzyme, the monoamine oxidase, which breaks down neurotransmitters such as the serotonin, norepinephrine, and dopamine. So it's inhibiting the breakdown. And so that's kind of how it works to create it. But the biggest side effect is, I like to say, you can't see, you can't pee, you can't spit, and you can't poop, okay? Those are kind of the things that we think about with these guys. They're just not great medications, and they have that tyramine that we have to be worried about. So cured meats, soy products, alcohol, vegetables. Guys, I don't know. I stay away from them. You should know about these side effects, but something to stay away from. Okay, atypicals. So we have bupropion, Wellbutrin. I see this used a lot. It is a very good medication. Oftentimes it's used in combination with an SSRI to kind of help bump people up, okay? So it is a stimulant type medication. So when I think of bupropion, I think of their heart, I think of hypertension, and it's something I want to monitor. It's not an absolute contraindication. It's just something we need to be aware of, okay? Trazodone is something else. We use that a lot for sleep, but it is considered an atypical antidepressant. Just something to think about here. And here's just another review of those different classes of medications. So we have our SSRIs, SNRIs, the TCAs, and then the MAOIs, okay? And just kind of the must avoid things to think about. Serotonin syndrome we'll talk about here in just a moment. And again, that suicidality in the first 2 to 3 weeks, just because we're giving that energy back to them, okay? All right. Quick little quiz here for you guys. Which of the following medications for depression is it's an absolute contraindication in a person with comorbid epilepsy? All right, so we have Lexapro, Wellbutrin, Zoloft, and then the Vibride. Go ahead, put your answer in the chat. If you know, this is a board question. Think of stimulant type medication here. So when we're thinking of epilepsy, something that might cause a seizure, okay? So what might cause a seizure? Okay. All right. So the actual answer is bupropion, guys, believe it or not. So when we think of bupropion, we think of it as a stimulant. Some people may use a little bit of bupropion in somebody who has ADHD because it can kind of help have that effect, that stimulant type effect. We also see this used in people that are overweight, as it kind of seems to be a little bit of an appetite suppressant. All right, however, it can really lower the seizure threshold, and it is an absolute contraindication in a person with a diagnosis of seizure disorder, okay, or epilepsy. We can go ahead and feel comfortable using SSRIs. So we have the Lexapro and Pristiq, that's venlafaxine. All of those are going to be okay. And somebody did answer D. So the Vibride is a serotonin modulator antidepressant. It is actually considered safe when taken at therapeutic doses. Okay. So moving on real quickly, we are down to only 8 minutes. So I'm going to go through these antipsychotics really quickly. Our typical antipsychotics, again, we're not using these very much. I think of that tardive dyskinesia. So where people have kind of you've probably all seen the videos during your lectures where it's kind of maybe in their mouth or in their hands. And so we think of when we're doing that test where we're in a tardive dyskinesia patient, that's that overreach and they don't have that good control of their hands, okay? And so we're thinking dystonia, Parkinsonism, these things are really severe. And then also that go along with any of our antipsychotic medications is gonna be the weight gain, the metabolic syndrome type side effects. Medications here, Haldol, really common. We see that used a lot in end-of-life care more than anything nowadays, or something just as a pretty effective immediate thing. These came from the mid-20th century. They block dopamine receptors in the brain. So dopamine, remember, we think of Parkinson's disease and dopamine. That's why we're seeing this happen, okay? When we decrease dopamine, we decrease things like hallucinations, delusions, and that disorganized thinking. But the extrapyramidal side effects, the tardive dyskinesias, the heart problems, QT prolongation, not worth it. Sudden death in older patients, we don't love these medications and we only use them as little as needed. And again, I think we're seeing them like the Haldol and stuff like that, end of life care. I see it all a lot. Okay, atypical antipsychotics, again, they just have a lot of side effects. So our friends with schizophrenia, like, we got to have some compassion. These don't necessarily feel that great to be taking all the time. However, we know that this is better than the dysfunction that a full-blown schizophrenia will have. So unfortunately, it's just the best option that we have at this time. But they really do primarily target dopamine receptors. The broader action really contributes to their efficacy in treating psychiatric symptoms, both the positive and the negative symptoms. So they have their biggest side effect is that weight gain, metabolic syndrome. diabetes, hyperlipidemia. So what are we going to be monitoring in these folks? I have it here on the slides, but what's really, really important to monitor when somebody's on an antipsychotic medication? I would arguably say their A1C and also their triglycerides, their lipid levels, okay? We want to make sure that we are not causing any further future damage and increasing risk of heart attack and stroke in these folks. Okay, olanzapine, risperidone, Seroquel, these are your medications that you're going to see folks on. I'm happy to bridge people, but when somebody has a diagnosis like this, it is important that they also have a psychiatrist that they're going to see, maybe every 6 months, and then I'm just kind of functioning as a person, as a closer touch point. It's a little cheaper. I'm not a specialist, so their copays are less. And so if folks are totally stable, we can go ahead and continue to kind of help them out here. But again, it's important that we can see destabilization. And so having a touch point with psychiatry is always important. An NP or an MD, but just making sure that they're connected to services, okay? So we see a little bit of these medications used for different things, but just because we're running out of time, I'm going to keep moving here, guys, and you can come back to these slides because this will be on YouTube. So come back and you can pause the video and read through this, okay? All right, anticonvulsant medications. So we see these different medications such as lamotrigine or lamictal, carbamazepine, Depakote, and we might use these medications to maintain bipolar and to maintain kind of mood stabilization in bipolar. They don't, come with the risk of that narrow therapeutic range as much as the lithium does. And so some people might do better on these medications. However, remember that Steven Johnson syndrome. We got to remember Steven Johnson syndrome when we're prescribing lamotrigine. Again, I am not writing these prescriptions for the first time for folks. Somebody comes in, they're stable, they're on these medications, they need a refill because maybe they've moved from out of state and they don't yet have a psychiatrist, and that wait could be months. I'm going to keep somebody on this medication. I go on, I always read the monitoring parameters for these medications. Make sure, do I need to be checking levels? What else do I need to be considering when folks are on these medications? But somebody comes in and, their parent brings them in and they think they have bipolar. I'm not reaching to start somebody on these medications. We're going to make sure they're safe. And if they're not safe, we're going to make a plan right away to keep them safe. If that means inpatient hospitalization, we'll work on getting them where they need to be. But I'm not going to just start somebody on these meds in the primary care setting. If you feel comfortable, if you take CMEs and that's where you decide to go with your practice, awesome. It's much needed. But I am willing to go ahead and bridge folks on this stuff, okay? And making sure that whenever somebody comes into you, and maybe you're not prescribing at all, but making sure you're reading about those drug-to-drug interactions. Okay, mood stabilizers, lithium salts, that's kind of our primary medication. However, that therapeutic range is so small, and we can have people get toxic or non-therapeutic very, very easily. We're going to be monitoring EKGs and stuff like that to make sure that they are not at risk for toxicity. And our common side effects, nausea, diarrhea, these kind of go through all of ours. And weight gain and acne can even happen with the lithium. So something really, really important, we can have drug-to-drug interactions with things like NSAIDs and other antidepressants. So it's really important that we get a good patient history. Again, I'm bridging. I'm not starting people on lithium. I'm bridging people on lithium, and I'm checking their range, their serum levels to make sure they're in the therapeutic range. However, I'm working closely with my psychiatry friends on this. Side effects, we think of leukocytosis, increased thirst, urine output, weight, tremors, thinning hair, hypothyroid, impaired memory, upset stomach, med interactions, and skin issues. So that's that acne and psoriasis. Again, the therapeutic range, 0.6 to 1.2. Okay, guys, just commit that to memory. Important to know, just for your board test. Narrow therapeutic index. Whenever you see lithium, it's something we got to watch for. Okay, really, really quickly, serotonin syndrome. This is something we have to be educate our patients on whenever we are prescribing. So I will start people on SSRIs. I start them on SSRIs all the time. I make sure they don't have bipolar disorder. Their NDQ is negative, and then we go over these side effects, okay? Rapid change in medication, agitation, confusion, tachycardia. It's kind of upping us too much, okay? If we're starting at the lowest dose, I think it's pretty, I've never seen serotonin syndrome, but if somebody is overdosing on their medication intentionally, then we may see these things happen. Make sure that if we are suspicious of this, it's a medical emergency. These guys are going to the hospital, okay? Things that you may see, confusion, agitation, rapid heart rate, dilated pupils, muscle twitching, sweating, everything's kind of amped up in serotonin syndrome, okay? It can get to the point of high fever, seizures, unconsciousness, right? Okay, but the treatment is really removing the offending agent. So we're going to get these folks into emergency care, get that medication out of their system as fast as possible. All right, last but not least is the malignant neuroleptic syndrome. Again, I'm probably not going to get to touch on this because I have to get off right now. Our RN friends are hopping on. Guys, go back, watch this on YouTube if you need to, but just remember, this is a medication. This is a medical emergency. This is a fever with the addition of these medications. You guys have a wonderful day. You're going to do so good on your exams, and I'm so excited to see you out in the professional world. Please go ahead and if you need to, sign up for our 3-day live review. And let us know if you have any questions. We do have those self-assessments. Take those. They are so helpful questions. You're never waiting for a bus ride or anything else. If you have your phone, be doing questions, more and more questions. You've got this. Good luck. Have a wonderful day. Take care. Bye.